Welcome back to Clinician's Brief, the podcast, the conversations behind the content. I'm the host of this program, Dr. Alyssa Watson, and I'm joined today by Dr. Christopher Lea, an associate clinical professor at Auburn University. Dr. Lea recently wrote a piece for Clinician's Brief entitled Top 6 Conditions Found During Canine Rectal Examination. So we asked him to sit down with us so that we could discuss in a bit more detail all of the really valuable information that we can obtain from this simple diagnostic, as well as what we might miss if we skip this really important part of our physical exam. Hi, Dr. Lea. How are you today?
I'm great. How are you, Dr. Watson?
Oh, I'm so good. Thank you for asking. We're really excited that you are able to join us. I think this is going to be a fabulous episode filled with great tips for our listeners. But before we get started, would you just introduce yourself, tell us a little bit about your background and how you ended up at Auburn?
Sure. Again, my name's Chris Lea. I did all my training at Auburn. Actually, I graduated in 1999. Went off to private practice for about 15 years. Enjoyed that greatly. I had the opportunity about 8 years ago to come back here. And people ask me, is it different? No, I still practice. I just have students with me. So I change my staff every 2 weeks with fourth-year clinical students. And it's me and actually two other veterinarians that we sort of run a general veterinary hospital. We call it the community practice within the teaching hospital, and we see, pretty much what anybody in general practice will see from day to day. And I consider myself pretty lucky to come back. It's been a great opportunity to actually, contribute to the mission of the teaching hospital and try to have a positive impact on early veterinarians as they start their career.
Yeah, that's wonderful. My community practice rotation at State was one of my favorites, and I feel like it really is, immersive and one of those things that's very, very important to prepare you when you're out there in the real world.
Yeah. 84% of our graduates will go into small animal or mixed general practice.
Mm-hmm.
So, we try to emulate basically a practice they may join, and they see the day-to-day things that, we could see, puppies in a pediatric series of vaccine to serious cases that, have serious diagnoses that have to be, basically worked on in continuation with other services. We see end-of-life conditions. We see dermatological. Just everything you can imagine. So, our goal is to get them practice ready. So we see a good bit of that every day and try to, again, have a positive impact on their career.
And so that's why you're just a great person to talk about today's topic, which is rectal exams. So I don't know if you've ever heard this little nugget of wisdom, but I have been told before that there's really only two reasons not to do a rectal exam. And one is if you don't have a finger, and the other is if your patient doesn't have a rectum. So how true do you think that is? Do you really feel that every canine patient, regardless of what they're coming in for, regardless of their presenting complaint, should get a rectal exam?
Yeah, I was taught the same thing, to be honest with you, Dr. Watson, and I think honestly, that goal is great if you can. I think when they asked me to write the article, I immediately emailed them back that I'd love to. I just want to be transparent. I don't do it in every case. That was actually my first sentence to them, and not that that's not wrong. I think it depends on your perspective. I think it depends on the patient. So, for instance, if you were an oncologist and you saw cancer every day, that would be a very important part of a physical exam. If you saw a geriatric patient, I think this is an important part of the exam. But you also have patients that aren't amenable to this, and that's been my experience. And I think at some point, if they're not symptomatic, you have to decide, is it worth somebody being hurt over or potentially the animal being hurt? And again, that's my personal opinion. I don't speak for all veterinarians for that. So I try to use some intuition, and that's different, of course, if there's clinical science. I think then it warrants, obviously, if you can't do that you can't perform the exam with the animal awake, you may need sedation. But for an asymptomatic patient, I think you have to use your best judgment. If you can do it, I think it's a great part. If you can, I think you have to use your clinical judgment. And again, that's my humble opinion.
No, I think that that's really important, valuable insight. And, especially as we're moving into, I think, a lot more discussion about having a more fear-free experience for the patient in the clinic. This is one of those things that it's probably not the patient's favorite part of the exam. And so weighing whether or not we need to do that. Do you have any tips about getting better patient compliance with rectal exam?
I don't. I mean, I use, I'm fear-free certified. We all are here at the vet school. I mean, as far as the community practice goes, but we use more medications than we ever have to try to decrease anxiety for pets. Cats and dogs. We combination of gabapentin, trazodone, both. Different drugs, trying to basically make the experience less frightening for them. So I think that can help, but I think there's some patients that still it will not work without sedation, and that's why I was like, you have to use your best judgment and sometimes there's no problem at all. I mean, I saw, I think last year, we do a lot of PT referrals. A dog came in for evaluation after a hemilaminectomy, and just routine anal, basically rectal, found basically an anal tumor. Dog was lovely, easy to work with. I will basically compare that to another one we saw who was kind of the same situation, but I was afraid I would hurt the dog, just from it jumping or getting out of the handler's arms and re-injure its back. I'm like, there's no way I'm going to be able to complete this part of the exam. So again, it really depends on the patient. Drugs can help it, but I think the bottom line is the patient, and they're all different.
When you do need full sedation, if the rectal exam you think is something that's very important, you don't want to skip it, and you need full sedation, is there something that you typically use?
Yeah, we go to dexmedetomidine with some sort of opioid, usually butorphanol, all the time. And I mean, we not even only for completing the exam, but we do that for like radiographs, ultrasounds. I mean, we probably use more sedation than I ever have. I think it facilitates a better diagnostic. Whatever you're doing, your chest X-rays will be better, your abdominal films will be better. Obviously, musculoskeletal images will be straighter. But yeah, and that's a great opportunity. So, for instance, if you're sedating the dog for whatever reason, but you could not fully complete the exam, that's a wonderful opportunity to do a rectal exam. It's also a great time to do a otoscopic exam and a better oral exam. So, everything we look at when they're sedate, we tell the students all the time, this is a perfect time to palpate the belly, probably more thorough than you ever
Mhm.
have been able to. Yeah, but, utilize the sedation not only for, one part of the exam, but as much as you can for those things, because those parts of the exams can be difficult too. Like a deep otoscopic exam could be equally as challenging, in some patients that you cannot get to the TM to see exactly what's going on. Same with the oral exam. You have to be a little bit careful with dexmedetomidine. They can still bite down on your hands and so forth, but you could probably get a better exam in the mouth with sedation as well.
Is there any utility to using topical anesthetics for, specifically for, rectal conditions?
Yeah, I thought I saw that on the questionnaire. I thought it was a really good question. I've never really thought about it, to be honest with you. We have a topical like 2% lidocaine gel that I'll
Mhm.
commonly use for, like, if we're gonna drain oral hematoma. We'll put that right onto the pinna, give it just a few minutes, and that just really helps with the stick of the needle. I've used it for some other things, but never for the rectal exam. I never really thought about it, but it would seem, I don't think you would hurt anything by doing that. I don't know if it would facilitate it enough to allow you to do everything you need, but I don't think it would hurt.
Okay. Do you have a systematic approach when you're doing a rectal exam? Like, could you walk us through a brief checklist of landmarks? What are you feeling for?
Sure, sure. So what we kind of tell our students is, I think everybody kind of does it a little bit differently, of course, but you probably need a really good hand, a dog, somebody holding the dog, obviously, and then using your dominant hand. A lot of times, I'll keep my non-dominant hand into the basically on the abdomen, and then just gently going in, obviously with gloves and lubrication into the rectum. Um, I usually go for the anal sacs. That's usually my go, where I would go to first. And most of the time, once you feel, I don't know, about 10,000 of them, you kind of get used to. They're all kind of variable sizes and usually spear shaped. Usually around, again, probably if the anus is a clock, around 4 o'clock and around 8 o'clock position. I usually feel those for symmetry. If they're firm or if anything's hard, then I usually will go a little bit further into the lumbosacral area. You put a little bit of pressure to see if there's any pain associated with that, and then try to kind of go 360 around the rectum, checking for any masses. If the dog is a male dog, you can attempt to feel the prostate. That can be challenging depending on the size of the dog, and then usually it can feel the pelvic urethra. And I try to do all those, and it's relatively quick, right? Because this dog is not going to appreciate it. So this could happen in a matter of 15 seconds, and then you have to make your clinical judgment, about what you feel and what else needs to be done.
Well, let's start with anal sac disease because that's kind of where you start your exam too, so that works well.
Yeah.
um, what are some similarities and differences in the presentation of anal gland tumors versus non-neoplastic anal sac disease?
When I first got to Auburn about 8 years ago, they asked me to give a lecture, and I was really excited. I was like, "Oh yeah, what would you like me to talk about?" And this was the dermatology course, and they said we need to talk to about anal sac, anal sacculitis, and perianal fistulas. I was like, "Wow, I see where I am in my career." But no, it's actually like you said, an important part of the exam. Probably for clinical signs, most of the time, I think with animals who have anal sacculitis, the owners are bringing the pets to us for a problem. And most of the time they're telling me, "Hey, Chris, look, my dog is consistently licking underneath the tail. My dog is consistently dragging its rectum across the carpet." So we kind of have a clue something's going on. Interesting with anal tumors, I don't think there's typically too many signs that I see, especially early in the disease. And I guess that would give you more ammunition. We should probably be doing more rectal exams. So I think early in the condition, we're not going to see a whole bunch. Potentially, if the animal is hypercalcemic because it has a malignancy, they may see increased thirsting urination. I've seen that before, and then we find the anal tumor that way. But a lot of times, anal tumors are incidental findings until they become big enough to have basically a problem with defecation. And the owner may see that and bring them to you. So I think it's basically one is more clinical than the other, except when anal tumors become fairly large.
So fairly advanced. What about
Yeah.
cytology? How often are you doing cytology, and how can this help to differentiate between those two conditions?
Yeah, I think cytology, we tell our students cytology is typically cheap, easy, non-invasive, and it's a great fundamental diagnostic tool. For anal sacculitis, it's kind of controversial. I did not write about it because there's not a consistent theme about anal sac cytology, but I use it. And I have some really good mentors here who are dermatologists who've taught me a lot about it, where I kind of gives me an idea of what's going on as far as inflammation and bacteria and so forth. So I think it's a great tool. There's not a consistent, I guess, a consistent theme how helpful it is. So I utilize that. But in essence, I'll just, as I express anal glands, I will actually put the secretions right onto a slide and stain it like any other slide and look at it in house. As far as an anal tumor, of course, that'd be a fine needle aspirate. So that would be an aspirate that we would actually use a special technique where we didn't actually, perform a fine needle aspirate right into the tumor and submit that cytology to basically a pathologist for review. Those are typically like neuroendocrine cells, but we definitely would need a pathologist to help us identify those. Those can be a little bit tricky.
Yeah, and so I assume you are using sedation when you're moving forward, if you're gonna go ahead and do a fine needle aspirate.
Yeah, and typically, yeah, it depends on the dog. I know that sounds a little crazy. I saw one about, I think it was about 2 years ago, a fairly elderly dog, and the anal tumor, Dr. Watson, was probably the size of an orange.
Oh.
And it kind of, not only was in the anal sac, but it was in the whole perineal region. So you did not need to perform a rectal exam to diagnose this one. So I actually just aspirated like I would any mass, and the dog did fine. But, for instance, if it was a small tumor, like, you palpate on exam, the size of maybe a BB, and you probably would need sedation to effectively try to enter that mass with a needle. So, yeah, I think it depends on the dog, but most of the time you would probably need sedation.
And when we're talking about anal sac neoplasia, are these always apocrine gland adenocarcinomas, or are there other masses that can actually occur within the anal sac?
Yeah, I think that there's the most common one is the Agasaka, the one you just mentioned. But you certainly can just have like a perianal adenocarcinoma that's not necessarily an African gland. So I don't think they're as common. So the most common ones are the Agasakas. You can see other ones in that area. You can also see melanoma and squamous cell carcinoma. Certainly anything is possible, but the adenocarcinomas of the African glands seem to be the most common, at least in my experience. That's what I've seen the most.
And when we see those, are there common sites that those metastasize to? Where should we be looking or following up for staging for those patients?
Sure. Yeah. So the most common situation we'll see is we'll identify the primary tumor, and then we typically go to ultrasound to look at the lymph nodes that drain the anal sac. So those are basically the regional lymph nodes around the distal aorta or the iliac lymph nodes and the sacral lymph nodes. Those usually are affected first, but I mean, a distant site could happen. Liver and lungs always could happen, but usually regional lymph nodes is where we go to first. In our experience, ultrasound has been very sensitive. You could CT the dog, of course, but ultrasound appears to be a fairly good diagnostic tool in those cases.
The road to treatment isn't always as clear as we'd like. Having a trusted reference on hand can make a difference, especially on your busiest days. The Clinician's Brief Algorithm Collection can help quickly guide you to your most confident diagnosis. With more than 100 management trees to reference, you can navigate your rule-outs, eliminate differentials, and choose your next steps. Get the Clinician's Brief Algorithm Collection at cliniciansbrief.com/algorithms. Let's move on and talk about a few of the other things that we can diagnose with rectal exam. So, how can a rectal exam help you localize, for instance, lumbosacral pain?
Yeah, so I added that when we were talking about it. I think it's one of the things I've noticed is sometimes I thought the dog had hip dysplasia and ended up having LS disease or vice versa. So again, kind of going back to your history and your physical exam, I think it's certainly a good attempt, if you would, to localize pain, because those two in the very beginning can look similar to you both with history and physical exam. So it can show you, I guess, more localization of pain associated with the LS joint compared to the hip joint. And certainly, like I said in the beginning, it can be the only differentiating factor you can find, or they can have both, and one's more clinical than the other. So I think it's a good trick with the rectal exam, if you can isolate it when you basically are performing it. If you can just gently push where that lumbosacral joint is with your index finger to see if you can basically, results in any discomfort for the dog. It helps you localize it. You can also do the tail jack, which is moving the tail around, would be a very similar technique.
Yeah, and what types of reactions are you looking for in your patient?
Yeah, typically, I mean, we don't want to cause too much pain, but we typically can see an animal vocalize or try to sit down immediately when you do that. Those are the two big ones I've seen. Or obviously discomfort. They look back, increased respiratory rate, that kind of thing.
Okay. And I'll be honest, I don't usually use a rectal exam in that capacity. So I was really interested in this. One of the things I kind of thought about was, could you ever use like serial rectal exams to help you determine whether or not therapy is helping, if you're giving NSAIDs or something? Have you ever used it in that capacity?
I never have. I saw that. I was like, I don't think it's unreasonable, especially if the dog would tolerate it, because it'd be no different than external palpation in the area as well. So it's just probably a little bit more sensitive. So if the dog was amenable to it, and you were persistently the one doing the exam, you probably could tell if pain was decreasing with your therapy. So it seemed reasonable if the dog was amenable to it.
Okay. Um, what about urethral neoplasia? So this is another really serious condition. We can find it on rectal palpation. Can you describe what the normal pelvic urethra should feel like, or should you even be able to feel that?
Yeah, I think in most cases we can feel the pelvic urethra with the rectal exam, and for me that has always been a kind of a tubular structure that's smooth but firm. That would be the best way I could describe it, especially to a student. So if you're palpating something, especially that feels irregular or asymmetric, so I guess something, hard masses on one side that you don't feel on the other side of the tube would certainly get our attention, or something that's you know distal compared to proximal that's firm and irregular, would make us concerned and potentially order some diagnostics on that dog.
And there are some newer molecular tests I know for urinary and prostatic neoplasms in dogs.
Right.
Um, yeah, and so I was always taught, to do things like traumatic catheterization in order to try to diagnose these, because we don't want to be doing, going through the abdomen, correct, when we're doing a biopsy or a needle aspirate. How are these tests changing how we diagnose these conditions?
Yeah, I think that's a great question. I mean, for me, I think it's made it easier. for instance, if we had, symptoms of some sort of stranguria, right? The dog is all of a sudden having difficulty urinating or blood in the urine, and we're investigating it in more depth. And regardless of your physical exam, if you just had hematuria on your urinalysis, you're probably going to want to do more tests. There's a problem somewhere, right, in the dog's urinary system. For me, I agree with you. Like when I was taught like traumatic catheterization, even doing an antigen test for the tumor, but these tests weren't perfect, so it could be a little bit tricky. But I think the molecular testing has made it a little bit easier. They seem to be very sensitive, very specific. Free catch urine samples. And I've been pleased with the results, especially the ones that we've diagnosed and sent to our oncology service for further workup. They seem to pair pretty well with the diagnosis. I think in general, I think it might depend on the oncologist. So I think more specifically, your question was, has that made those techniques completely, outcasted? And
Mm-hmm.
I think for me, the molecular testing has been very useful. In general, probably a biopsy is still the gold standard. But I think that's going to depend on so many factors, the oncologist, the health of the dog, the owner's wishes for treatment and so forth. But I've seen a pretty well correlation. And certainly if you're not doing them, I think you're gonna be missing out. I've been really, really pleased with our results.
Yeah, that's wonderful when we've got advances like that that really
Oh
help
yeah.
us and can be easier on our patients too.
Absolutely. Yes, absolutely. Traumatic catheterization just sounds horrible.
Doesn't it?
Oh yeah.
So, let's talk a little bit about the prostate. As you said, sometimes this can be difficult. I find this difficult in really large dogs. I am a not large woman and I
Sure.
don't have very big fingers.
Yeah.
And so, prostatic palpation is one thing that I kind of struggle with. What conditions can we usually find with a rectal exam?
Yeah, I think it's basically the size and shape of the prostate gland, and I agree with you. Again, no exam is perfect. No dog is perfect. The size of the dog, the size of the examiner, all play into factor. I have struggled to even just touch the distal end of the prostate, just because the size of the dog and the prostate's mostly in the abdominal cavity. So all those are in play. If the dog is amenable to the rectal exam, I usually will put my non-dominant hand on the abdomen and try to push towards the spine, trying to basically push the prostate back to my other hand so I can feel for it. We're always checking for symmetry, basically, and smoothness and pain. Certainly, if you have any type of prostomeglia in a dog who's neutered, that's a red flag. Like that to me is like that's a concern. That probably should never have prostomeglia in a dog who's been castrated. If the dog is not and the dog is intact, then the category of conditions are a little bit more. So that we see a lot of benign prostatic hypertrophy in dogs, see some bacterial prostatitis, and of course we see some tumors. So you have to kind of go through all the decision trees of how to delineate those differences and so forth.
And what clues can you get just from palpation? You talked a little bit about symmetry. So,
Yeah,
yeah.
for sure. Like, and one side of the prostate feels hard and enlarged, and the other side you can't feel, it would get my attention. But most of the time, my benign prostatic hypertrophy is not too painful, maybe mildly enlarged, but generally very smooth and equal on both lobes. And same with bacterial prostatitis, probably just a little bit more painful on palpation. So I think the symmetry for me is probably the difference, and probably the firmness of the prostate.
And then how do you move forward, with biopsying those?
Yeah, I think it's the same thing. So I think your decision would be simply, how do we image it? So again, we do a ton of ultrasound here. We are blessed to have just really gifted ultrasonographers and radiologists. So we utilize that, almost daily. And of course, sedating the dog, as we talked earlier, will facilitate all of this. So imaging in some form. I think the molecular testing can help in those cases as well. It's probably not as there's a little bit of differences between the prostatic adenocarcinoma and the TCC that could potentially be emitted from the bladder into the prostate. So that's where I guess the Achilles heel for that molecular testing could occur. So I don't think oncologists completely agree with how useful it is in those cases, but you may have to eventually biopsy those for a true diagnosis or a cystoscopy or a scoping.
So the final category in your top 6 was my favorite because it was miscellaneous conditions. And
Yeah,
so because
yeah,
there's so many, there's this
right.
myriad of conditions. So could you run through a couple of those as well as maybe tell us what's the most surprising or unusual thing you've ever found on a rectal exam?
Yeah, I mean, I think one part about fun part about practice is no day is the same, right? So,
Mhm.
we see all types. So, like shortly after I was working on this article, ironically, we had a dog who I've seen for years and who's had on and off colitis. Um, you know, they the dog ended up having a rectal mass not on the anal sac, actually right off the rectal wall, and it was like a pedunculated mass. And I was like, wow, this is kind of an outlier. Not associated with the anal sac, and it just completely random. And that actually turned out to be a plasma cell tumor, and they
Oh,
actually had it
wow.
removed. So yeah, so kind of a incident, a strange finding. But I think there's all types. Of course, that dog was clinical too, with having tenesmus and so forth. So um, again, I think if clinical signs are still pointing to that area, is continually to look. And if you're not finding something, maybe look in different directions with different imaging. Weird things that I've seen, probably the most uncommon thing I remember seeing a little Cavalier King Charles a couple of years ago who had up all night having diarrhea, and so I was talking to the student, and we were talking about the difference between large bowel and small bowel diarrhea, and trying to help us with which test should we run and so forth. So the dog was lovely. We still see the dog today. So I just did a quick rectal exam, and I pulled out like a huge amount of cloth and fabric, so just like basically a colonic foreign body, right? So, the
Mhm.
dog was immediately felt better after that. So who knows what you would find? I think, any type of signs of tenesmus, and if you can, obviously a rectal exam would probably be the best place to start. But, hemorrhoids, rectal strictures aren't super common, but possible. Tumors, like I said, that little plasma cell tumor, I've never seen anything like that. So anything's possible, certainly in that area, and it can be hidden pretty well given the dog's anatomy.
Yep. I've definitely found a couple, large stones, urethral stones. I found one in
Yeah.
a female dog
Oh, wow.
that was blocked, and yeah, it was so surprising. But I could feel it in there, and I
Yeah.
could, feel it as I passed a catheter and pushed it back
Yeah.
in. So that
Yeah.
was
Yeah.
crazy.
Yeah. Unlucky enough to find a female dog blocked. I've only seen one in 24
Mhm.
years. So, what kind of dog was it?
It was a little dog. I think it
Yeah.
was like a Shih Tzu or something like
Yeah.
that. Yeah, not
Yeah,
very
I had a
big.
pug. Yeah, I had a pug. I bet it was 12 years ago, and multiple urinary stones, and yeah, it's kind of the same situation. I was like, wow, there's probably a stone right here in the pelvic urethra, and I just thought to myself, like, how unlucky could I be to have a female dog who was obstructed? So I think the dog absolutely did fine, but it was one of those situations where, wow, I didn't think that would happen.
Yep, exactly. Those things that they say doesn't happen, but it really does.
Yeah, yeah, didn't read the book that I read.
Yep, exactly. Well, that was wonderful. That was all of our questions about rectal exam today. These are some great tips. I'm sure that I'm going to use them moving forward, and hopefully our audience learns some things too. Before I let you go, though, there's one more thing that we do at the end of our episodes. Our regular listeners know that this is the time for a few quick, fun, rapid fire questions for you. So these are
Okay,
just some would you rather questions. No right or wrong answer. It's just for fun.
okay,
All
good.
right. Okay. So would you rather be the head veterinarian at a state of the art diagnostic facility, or would you rather run like a small pop up street clinic with limited resources?
State of the art.
Yeah. You like all your bells and whistles and toys?
Well, I love diagnostics and trying to get that diagnosis right. Once I have the
Mhm.
diagnosis, I can manage, the patient better and actually counsel the client. Don't you hate it when you can't figure out what's wrong with the pet? So even if it's bad news, I feel like I need to know, and I can counsel, the client with my experience and try to figure out the best treatment. So I think I'm spoiled here, and blessed here, but state of the art diagnostics for my patients, absolutely.
Okay. Would you rather assemble an e-collar without the help of your technicians, or would you rather write an international health certificate?
Oh gosh, neither. I'm not smart enough to assemble an e-collar. I say the same thing about a pet carrier. It's very similar to me. We
Oh, yeah.
basically disarticulate the pet carrier to get the cat out, and I tell the students it's an IQ test to get it back together, and I walk out of the room because I can't do it. So that's what our technicians are brilliant, and they do that for me. We do quite a bit of international health certificates, and there's always a crisis involved. I don't know if that's how you feel as far as the timing of the export, the information, trying to decipher when the last rabies was, if the dog was microchipped before or after. So I would say neither are good. I'd probably go with health certificate over the e-collar. So, because I could probably call the Department of Agriculture and get help.
Yeah, they're very, very helpful. I think for me, it would depend on whether or not I had to put the e-collar together in front of the client, or if I could like hide away and try to figure it out.
Yeah, I have never been good at them, to be quite honest with you.
All right. So would you rather practice without radiography or without ultrasonography?
Oh, without radiography.
Oh yeah, you need to have your ultrasound?
Yeah. I would, again, we're blessed. We have wonderful radiologists who are brilliant. So I would probably pick ultrasound over radiography.
Would you rather take a new position every year for the rest of your career, or would you rather never be able to leave your current job?
I don't think I'd want to leave my current job. I think people have asked me again. The students are a lot of fun. I enjoy veterinary medicine, but I enjoy being with them and trying to teach them some of the mistakes I've made and try to get them ahead of the game. Leaving your job year to year would bring challenges and opportunities, but I think I would prefer to stay in my dream job.
Well, and you get a new crop of students every 2 weeks, like you said.
We
so
do.
It is kind of like a new job. Yeah.
It is.
So.
I tell my clients, because they ask me, like, why is this taking so long? I'm like, I change my staff every 2 weeks.
Every 2 weeks.
Yeah. It's like Groundhog Day on every 2 Mondays here. And, my students come in with totally different experiences. Some of them, parents are veterinarians. They've grown up in a veterinary clinic. They can run the clinic without me. And others are, maybe a predominantly large animal background where they've never even run a heartworm test before. So, we have all types of backgrounds and plenty of patience and, again, trying to have a positive impact on their career.
All right. Final question. If they could both rate you on Yelp, would you rather get a review from your last feline patient or from your last canine patient?
Ooh, wow. That's a tough question. So I always say I'm I'm more of a dog person than a cat person, but I have a reason. Is my wife, who I've been married to for 24 years, is severely allergic to cats. So when we first got married, I had to shower when I came home because she would start to have basically, hives and an itchy tongue. So I've been more of a dog person, but I still love my cats. We have a fantastic partner in the service who's a feline specialist, and she gets most of the cats unless she's not here. So I'll go with dogs.
You'll go with dogs. All right.
I'll go with dogs.
Well, that was all my questions. They were fabulous answers. Thank you so much.
Thank you. They were great questions.
Thank you for listening to today's episode. If you enjoyed our episode, you can find us wherever you listen to your favorite podcasts, including a video version now available on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@briefmedia.com. Clinicians Brief the Podcast is a Brief Media production, produced by Alexis, Ussery, and hosted by Dr. Alyssa Watson.